Every month. Even cut my hair.
Welcome to our webinar, Breaking New Ground in COPD, Latest Treatments and Advances in Management. My name is Kelly Malcolm, and I will be your moderator today. We are pleased to welcome you to the CME panel discussion hosted by the Division of Pulmonary and Critical Care Medicine here at the University of Michigan. Our panelists today include Dr. MeiLan, Professor of Medicine and Chief of the Division of Pulmonary and Critical Care Medicine, Dr. Wassim Labaki, Assistant Professor in the Division of Pulmonary and Critical Care Medicine, Dr. Jose de Cardenas, Founder and Director of the Interventional Pulmonary Program at the University of Michigan, and a Clinical Associate Professor of Medicine and Surgery, and Dr. Doug Arenberg, Professor of Medicine in the Division of Pulmonary and Critical Care Medicine at the University of Michigan. The goal for today's discussion will be to help you understand new treatment and management options that are available for COPD patients, so you can better advise and care for this patient population. Before we begin, just a few announcements. This discussion is free from commercial bias. And here are some financial disclosures on the screen. Please use the Q&A or the chat buttons at the bottom of the screen to ask any questions. This course offers 1 hour of CME credit. To claim your credit, please log into your Cloud CME account. You must claim credit within 7 days of the course adjourning. You will receive instructions on how to complete the evaluation and claim credit following the course. A video recording of today's discussion will be emailed to you after the course. If you would like more information on other upcoming CME courses, please visit umich.cloud-cme.com. And we will adjourn today at 3 p.m. Thank you so much for joining us. We will now begin the discussion with our first question. What are the most exciting recent advances in COPD treatment this year? And I'm going to throw that to Dr. Labaki.
Thank you, Kelly, and welcome to our audience. So I must say we had a very important and very exciting year in terms of COPD treatments. And this is because we had 2 novel pharmacologic treatments approved by the FDA in 2024 for the treatment of COPD. And these treatments are ensifentrine and dupilumab. And just to put this into context, the last time we had a pharmacologic treatment approved for COPD by the FDA was more than 10 years ago. And then come 2024, and we have 2 treatments in the same year. So this cannot be any more exciting, for our patients and for our pulmonary community. This is a big deal because, as you well know, many patients continue to experience a high burden of disease and high activity of disease despite maximal inhaler therapy, despite pulmonary rehabilitation. So these new treatments, ensifentrine and dupilumab, can help fill that gap in terms of helping someone who continues to experience a high burden of symptoms despite maximal inhaler therapy, or help decrease the frequency of exacerbations in someone with recurrent COPD exacerbations. So these treatments have the potential to significantly enhance COPD care for our patients.
Great, thank you so much. Our next question, what is ensifentrine and how is it expected to improve outcomes for COPD patients? Dr. Hahn?
All right, thank you, Kelly, and it's a pleasure to be here with all of you virtually, or who might end up watching a recording later. So ensifentrine is a PD3, PD4 inhibitor. This is not the first time we've had this class of medications in COPD. When I was a fellow, I was using a lot more theophylline, which is still in the same class. And then later we had roflumilast, which was also in the same class. And I don't think it's fully understood how these medications work. I think we know they have a bronchodilator effect. They likely have an anti-inflammatory effect. The good thing, though, about ensifentrine is that it's nebulized as opposed to oral. And we have had a lot of problems with side effects with theophylline and with roflumilast that we are not seeing with ensifentrine as it's nebulized. So I think that is one huge advantage in our ability to use the medication for our patients. I think it's important to know, though, that the studies that were done with ensifentrine, very few patients, if any, were on triple inhaled therapy. So it's a little bit hard, and I'm actually on the GOLD committee. It was a little bit hard for us to try to figure out where to place it. And so we finally decided it does have a bronchodilator effect. It did show improvement in symptoms. Interestingly, they were actually also able to show reduction in exacerbations, but it was not in patients on triple therapy, which makes it a little bit hard to place in terms of add-on, in terms of with triple therapy. Those are studies that we still need to do. So, in GOLD, we went ahead and placed it as an add-on to maximal bronchodilator therapy, LAMAs, LABAs, et cetera, if a patient is still dyspneic. I can tell you, though, I'm also on UpToDate and help to edit the section for UpToDate as well. And we have a slightly different lens with UpToDate. GOLD is an international document, and ensifentrine is right now only available in the US. So we decided we do have a slightly different take on it on UpToDate, and do say, or about to say, we were actually working on the document last week, that, if you have a patient, for instance, that doesn't tolerate inhaled steroids for some reason, it is an option that may also have an effect on exacerbation reduction. And it's just something to kind of think about in the back of your mind. But obviously, for every single patient, I think we need to have a tailored approach. What we do need to realize, though, just from a super practical perspective, is that it's, there's definitely a higher hurdle to meet, prior auths, et cetera, that we have to kind of go through if you decide that you want to use this medication. So it's probably not going to be and due to the expense, it's not going to be your first line in COPD, but definitely I think something we're all exploring in terms of an add-on. I have to admit, I have not seen a ton of patients back yet to find out how they're doing. I don't know. Wassim, have you begun to see anybody back?
I've had a patient who had a substantial improvement in their dyspnea exertion after using it for about 2 months, but we shall eventually see how it plays out for many different patients out there in the real world, but exciting results so far.
Great. Our next question, how do biologics like dupilumab fit into the COPD treatment landscape? And Dr. Labaki?
Yeah, so dupilumab, which again is one of the medications that were approved by the FDA for COPD last year. It's a biologic, and it's a fully human monoclonal antibody that targets type 2 inflammation by specifically inhibiting the interleukin 4 and interleukin 13 pathways. Now, dupilumab has already approved indications for a number of conditions, including eosinophilic esophagitis, asthma, nasal polyposis, etc. But this is, the first time a biologic, and specifically dupilumab, is being used in COPD, and specifically eosinophilic COPD. So the evidence base behind dupilumab comes from 2 randomized controlled trials, the Boreas trial and the Notice trial, both published in the New England Journal of Medicine in 2023 and 2024. And basically, these trials enrolled participants with COPD who had a history of exacerbations in the prior year despite being on triple inhaler therapy. But very importantly, these participants had evidence of type 2 inflammation as indicated by a blood eosinophil count of 300 per microliter or more. Now, these participants were randomized to either dupilumab or placebo, and the primary outcome was the rate of exacerbations during the first year. And the results of both trials were very similar. And basically, participants who received dupilumab had a 30 to 35% reduction in the rate of COPD exacerbations compared to those who received placebo. And this is quite remarkable because, again, remember, these participants were already on triple inhaler therapy. So the way dupilumab fits into a treatment algorithm here is if you have a patient who has recurrent exacerbations despite being on triple inhaler therapy, a LABA plus a LAMA plus an ICS, and they have evidence of a high blood eosinophil count, specifically 300 or more, then you should think about dupilumab. And in the new GOLD guidelines, this is where dupilumab is positioned in the treatment algorithm.
Our next question, what role do endobronchial valve therapies play in managing COPD and who can benefit? Dr. De Cardenas.
Hello.
It's on.
Hello, and thank you. It's a real pleasure to be with you all. And so going to the question, I think we were very excited, and we're still very excited because there are new developments in terms of what we're learning with who can benefit. I think that the overall consensus is that those patients with homogeneous or heterogeneous, very severe or severe COPD with evidence of hyperinflation, and those, and this is very important, those who present or do not have, those who do not have collateral ventilation can benefit from endobronchial valves. And one of the exciting things that we always discuss in the community is that there has been new data showing that at least at 12 months, endobronchial valves have still the same results, the same benefits that long volume reduction surgery, right? In terms of improving the lung function of the patients, the exercise capacity, as well as health benefits. There has been also some development on how to optimize the results, right? There was a new study, for example, showing how to improve, although most likely, or you already know that it's expected in the initial studies that there was a report of 30% of complications secondary to pneumothorax, real complications, and this was a study recently published in Chest in August of the last year, 2024, that actually the decrease of complication, that there was a decrease of complications up to 26%, and not all of them required chest tubes, which is very important. But most importantly, how to decrease those complications, this is what we have learned. For example, one big tip that we learned from other colleagues from other institutions is actually, for example, during the procedure, to decrease the FiO2 that the patient is being administered through the ventilator. Another thing that we also learn is that although, for example, for those patients who do not, in the strata, which is a quantitative assessment of the CAT scan, in those cases who still have 80 to 95% of completeness of fissures, meaning that they do not have complete fissures, but they're still between 80 to 95%. In 50% of those patients, we will still find negative collateral ventilation when we confirm, or we try to confirm that bronchoscopically. And it also opens a new opportunity for those patients who before were negated to have endobronchial valves.
So I wanted to quickly ask, so Dr. Labaki is the head of the kind of the medical head of our lung volume reduction program, and Dr. Cardenas is the interventional kind of partner. For those of you who are out there, maybe you're in a community group, maybe you don't have an interventional pulmonology, you might be wondering, well, how do I know who to refer? And what testing should I get done beforehand? What testing are they going to do there? And what should I expect? So maybe I'll start with you, Wassim. How does someone in the community know when to refer and what should they order? And then Pepe, when they get here, what do we do and what should they expect? So I'm going to start with Wassim.
Yeah, definitely. So for people practicing in the community, especially in primary care settings, things I would look for is most people with COPD must have at least a set of spirometry results at some point. So if your patient has, generally speaking, FEV1 less than 50% predicted, this should raise awareness about their potential candidacy for lung volume reduction. If they have a DLCO less than 50% predicted, which may indicate some problem with gas exchange, which may in turn be due to emphysema, this should also raise further awareness regarding the potential candidacy of this patient for lung volume reduction. But also, very importantly, if you have some set of imaging, ideally, a chest CT. Let's say a patient got a low-dose chest CT for lung cancer screening, and the radiologist mentions some burden of emphysema, like some moderate emphysema. When you put it together with FEV1 less than 50% predicted and or the DLCO less than 50% predicted, just refer these patients. Additional workup we could do in our clinics is obtain lung volumes through plethysmography to confirm hyperinflation and air trapping, and eventually get like a more detailed or more updated CT to look into their candidacy. But this is where I would put it. I will keep it simple, like presence of symptoms, FEV1 less than 50% predicted, and some report of emphysema on a recent CAT scan.
So when you make a referral to our clinics, especially the University of Michigan, you should expect to have one of those patients being evaluated by our colleagues who are very specialized in managing COPD patients. And then, as Dr. Labaki mentioned, we complete the workup with additional testing, for example, arterial blood gases. If the patient needs a transthoracic echo, we coordinate that as well. Or if a nuclear medicine CAT scan in order to evaluate what will be the best target in order to put the valves. One characteristic that makes, I think, our institution very unique is the great collaborative environment that we have. And every single case that is seen by a pulmonologist referred for potential advanced therapy for COPD is discussed in what we call the lung volume reduction surgery meeting that is held twice a month and is led by Dr. Labaki. In those meetings, every single patient that you refer to us is discussed with our thoracic surgeons. All the pulmonologists who are presenting cases or are involved in COPD are present. Also, our schedulers, our respiratory therapies as well. The whole IP team, we have 3 fantastic IP faculties managing those patients, and we try to expedite those cases, right? So once a decision has been made in terms of this patient might benefit from medical therapy or change ABC option for him, or lung transplant or lung volume reduction or endobronchial valves, we try to expedite those cases to complete the workup and accelerate also what intervention could be done on those.
What kind of outcomes might we expect in the best case scenario?
Yeah, so we look at all the data we have, all the way from PFTs to CT, to all the studies that Dr. Cardenas mentioned, to identify patients who have a good chance of responding to therapies. So we expect a significant improvement in shortness of breath, and this is due to the reduction in the hyperinflation and air trapping once these procedures are performed, whether it is through valve or through the surgery, a significant improvement in exertional capacity and quality of life, and also an improvement in some of the physiologic metrics that we measured. I've had a number of patients who had their FEV1 double after the procedure, and the residual volume be cut in half after the procedure. And it was, yeah, thank you. And it was really nice to see how the physiologic improvements are also going in line with the symptomatic improvement that people are experiencing. And, in the right patient, these therapies can have amazing outcomes.
Question for you guys. Are there any red flags or stop signs that tell you this person should not have this procedure done?
So just to, before I forget, well, let's finish back with your question. Yes, so, and that's why we are very thorough in terms of doing the workup. For example, on CAT scans, we see if the patient presents with bronchiectasis or with a worsening lung nodule, right, or with any other finding that requires a higher priority attention or follow-up, or a small evidence of a small airway disease and no hyperinflation, or patients with paraseptal emphysema. Those are facts that tell us this patient might not benefit. PFT is super important, right? So if there is no evidence of hyperinflation, this patient might not benefit, because that's the whole point of lung volume reduction, either bronchoscopically or surgically. If the patient has hypercarbia, very high hypercarbia, or evidence of pulmonary hypertension, we have to try to be very, very selective as well. And if the patient is, and that's why we also request the patient to be in pulmonary rehab, engaged already or completed, because we want very active patients, because it's just not about putting the valves, it's about also the follow-up. And I think that's very unique also at Michigan, that once we receive those patients, we go along with them, right? We do a very exhaustive follow-up, and we carry them, and they belong. I have patients 4 or 5 years following with me already, who already have received the valves, because there is a link that we develop. One important thing that I also wanted to mention, we also learning this in the last couple of years with valves, although in some cases we put the valves and they're very beautifully placed, and but the lung will not collapse completely. And despite of that, we have objective and subjective data that the lung has decreased moderately in terms of volume, and the patient already has the benefit. So those partial collapses, right, should be still accepted as beneficial to the patient, right, because there is objective and subjective data suggesting that.
So I think several of you hinted at this already, but how can imaging tools like CT scans improve COPD management beyond diagnostics?
So I think, we actually added a whole section in the, I think not the last gold update, maybe the one before that, on the use of CT imaging in COPD. I don't think we're quite at the place where every single patient with COPD is going to get a CT, but we're getting close because, as Dr. Labaki mentioned, any patient that has an FEV1 less than 50% might be a candidate for a valve, and you aren't going to know that unless you get a CT scan. There might be differential diagnosis questions. And then, as we're going to talk about in a bit, many of these patients qualify for lung cancer screening. So there's, I don't know, it's probably 75%, I bet, of patients, at least in my practice, end up benefiting, I think, from a CT scan in some way. And we're definitely exploring additional ways of utilizing that data beyond just the visual scoring. So, for instance, here at Michigan, we get emphysema scoring on all of them. We even get small airways disease scoring. And that helps us to, for instance, better score patients for transplant and decide on which patients might need valves. There's additional imaging that has to go in to determine fissure completeness for valve candidacy. So I think that both the qualitative and quantitative aspects of imaging analysis are becoming increasingly commonplace in COPD.
So what is the connection between COPD and lung cancer, and how does this influence care? Dr. Arenberg?
Well, so we know that not just the shared risk factors, it's not just the fact that tobacco use is a shared risk factor for both COPD and lung cancer, but even individuals who have never smoked, who have COPD, are at heightened risk for lung cancer. And it's a pretty substantial risk. The data would be, if you take a general population person whose risk for lung cancer is quite low and change that into someone who has COPD but never used tobacco, their risk is about 4-fold higher to get lung cancer. So we know there is a connection. We don't know the mechanism behind that connection. The most obvious, of course, is the shared risk factor, which is tobacco use. And as MeiLan was hinting at earlier, many of our patients with COPD are eligible for lung cancer screening. There is, if you will, a sweet spot. Cancer screening in general is, if we acknowledge that life is 100% fatal, cancer screening is useful only insofar as it changes your chances of dying from that particular cancer. That's true whether we're talking about well-known screening modalities like colon cancer screening or breast cancer screening or even cervical cancer screening and prevention, but it's absolutely true of lung cancer screening as well, which is to say that lung cancer screening is best used in people who are at high risk, but otherwise pretty healthy. We do know that, alluding to the GOLD criteria, for example, GOLD stage 1 and 2 individuals are at very high risk for lung cancer and have enormous potential to benefit from screening, not just because of the reduction in lung cancer mortality, but reduction in overall mortality. Most of that mortality reduction is lung cancer. Individuals with GOLD stage 3 and 4 have not been shown to benefit from lung cancer screening, in part because they have such high cardiovascular comorbidity and potential mortality. So the shared risk factor really complicates the issue with lung cancer screening. But step one in identifying people who can benefit from lung cancer screening is simply taking the most accurate tobacco history you can. We, I think, as a profession, probably fool ourselves when we think we're doing a very good job of that. I certainly looked at this a lot, and our ability to identify people through electronic medical records who should be targeted for screening is limited in large part by our inability to identify those who have the greatest potential to benefit. So shared risk factor, COPD by itself increases risk for lung cancer. And certainly a lot of our COPD patients get imaging for other reasons, and we find pulmonary nodules that we end up having to investigate. But I think there's a lot of room for growth and improvement in the global our approach to using lung cancer screening in patients with COPD.
What barriers exist to getting more eligible patients screened for lung cancer?
So take the microphone again. So, well, I think, I alluded to one of them, which is I would say tobacco is such a 800-pound gorilla in terms of its impact on lung cancer risk that we have treated it as a blunt instrument in terms of recording medical histories in the chart. I think if we get a little more precise about recording, particularly in electronic medical records, where that then becomes a resource for identifying individuals who could benefit from other preventive therapies, if we get better at identifying individuals who use tobacco. I think, too, we as a profession are still absorbing the data that indicate that lung cancer screening is one of the most effective cancer screening modalities we have. I think we are creatures of habit, and which means we don't change fast. It took many years for breast cancer screening to go from its early years to where probably 80% of women eligible for mammography go and get themselves screened. Colon cancer screening's been around for 30 or 40 years, and I think we're at 60% of people who are eligible for colon cancer screening who get that done. Right now, the most optimistic estimates are that of those who are eligible for lung cancer screening, we're reaching about 20%. And that's a very optimistic estimate. Some still stick with their single-digit numbers, which is to say that we've got a long way to go as a profession in educating ourselves, first and foremost, and then educating our patients. There is, I think, an additional burden in identifying people eligible for lung cancer screening, which is that there's a lot of stigma that goes with tobacco use. And for reasons that I can't go into great detail on, there's a lot of stigma just associated with lung cancer. I always like to look at it this way, is that most people who started using tobacco did so as a teenager. Raise your hand if you've ever been a teenager, right? We weren't known as teenagers for making long-term wise decisions about our health. And that's a built-in feature. It's not a bug. Teenagers are known to take risks. I think it's part of our evolutionary DNA, separating from the tribe or whatever you have. You want to go back to evolutionary terms, but teenagers take risks, and they take risks, and they are rebellious, and some of that is exploited by the tobacco industry remarkably effectively, with billions of dollars of advertising very effectively aimed at the 14 and 15-year-old market. What we call teenagers, they would call replacement smokers, which is really disgusting, but it's true. So people who use tobacco as adults should not be blamed. Once you are addicted, it's no longer a choice. And so it's not as if we're working with patients who have flawed character. These people who smoke are laboring under the burden of an addiction that we should help them with. Tobacco use is associated with a lot of public health stigma, but that stigma has no place in the exam room. I think we should approach our patients who use tobacco with empathy and with resources. I don't know if I've gone off on too much of a rail here, but I think we have to be better at recognizing that people who are at risk for lung cancer aren't to be subjected to the societal stigma that seems to attach itself to this disease.
Doug, do you have any kind of quick thoughts on best practices with respect to smoking cessation guidance, as well as maybe institutional best practices for improving lung cancer screening rates?
Well, so I think a lot of institutions are approaching this differently. I think one of the things that if you want to improve behavior, measure it. Pretty soon, lung cancer screening will become a quality metric under the HEDIS umbrella. I think once you do that, you'll see screening rates go up everywhere. What that means from our perspective is we need to be prepared with the resources. We need to provide our primary care workforce with the tools to understand and do shared decision making with their patients, which takes time. I think our primary care workforce is enormously burdened with the number of tasks they have to do, and best practice alerts and immunizations and so on and so forth. Whatever we can do as an institution to support them, including providing navigators whose only job it is to provide shared decision making, make sure that people who are referred for lung cancer screening are both eligible and capable of benefiting from cancer screening. So I think institutions that invest in this realize what a good idea it is. It's a win-win-win scenario. It's win because it's good. It's the right thing to do. It's a win for our patients, and institutions that do this right. It helps their bottom line, which should not be the driving force, but it is in many ways. And without a margin, there is no mission. So if we want to support our mission, we can do so by supporting lung cancer screening. So I hope that institutions out there that are considering this will take that into account.
Dr. Labaki, did you have anything you wanted to add to that?
No, Dr. Arenberg really touched on the major points. The only thing I want to emphasize is awareness, because when I see patients in clinic, they seem to be very aware and knowledgeable of a number of preventive or screening measures out there, like vaccines. They always ask me, am I up to date on my pneumonia vaccine? Or they can bring up, just generally speaking, there are many forms of cancer screening, like colon cancer screening, breast cancer screening, cervical cancer screening, etc. But lung cancer is not up there in terms of awareness. And I know that anecdotally, at least, because when I bring it up with my patients, because I identify them as good candidates for lung cancer screening, it seems like new information to them, something they have not heard about, something they're not familiar with. And I definitely take this opportunity to educate them on what it is, what it entails, and have this shared decision making about risks and benefits. And I think, like Dr. Arenberg was saying, the numbers support that at the very best, 20% of people who are eligible for lung cancer screening are getting this screening. It is multifactorial, but a lot of it has to do with patient and provider awareness.
Just one quick plug for some resources that are out there for our colleagues who are watching. If you need a resource to help discuss, have a nidus of discussion with your patients on lung cancer screening, there are a number of very good ones out there. You can go on Google and just look up lung cancer screening, lung cancer shared decision making. There is we put a webpage together at the University of Michigan. Its title is really simple: Should I Screen? All one word.com. It has all the information that both providers and their patients may want to know. It's written at a level aimed at most of our patients. It has both the information about lung cancer screening as well as a built-in risk calculator that can be useful. But the American Thoracic Society has a handwritten lung cancer screening decision aid. The National Lung Cancer Roundtable is another great resource which you can look up that has enormous resources available to those who are thinking about how to put this on the table with their patients. The American Cancer Society, of course, has a lot of resources devoted to lung cancer screening, and they are the main sponsors of the National Lung Cancer Roundtable, whose mission it is to get more people screened and prevent more lung cancer deaths. So there are lots of great resources out there. If you're thinking about how do I get this into my practice, you can Google lung cancer screening resources, and obviously plug for our own shouldiScreen.com, which we're very proud of, and it's in 2 different languages right now and should be translated to a 3rd language pretty soon.
Great, thanks so much. So in addition to the advanced therapies, we've been discussing what else can patients do to improve their respiratory health. Dr. Han, you want to take that?
Sure. So, it's a combination of, I think, kind of defense and offense. So, um, obviously we want to reduce risk factors. So it's smoking cessation, as Dr. Arenberg talked about. I mean, one of the things that everyone's been talking about the last few weeks has been air pollution due to the heartbreaking situation in Los Angeles right now. There's actually emerging and not even kind of, we're beyond emerging, I would say established at this point, data to suggest that air pollution not only exacerbates existing lung disease, but actually can cause lung disease. And we worry most about, I think, some, the vulnerable population. So the young, the pregnant, those with chronic conditions, the elderly. So we want to kind of do a better job of educating our patients about other radon within the home, things that might impact their respiratory health negatively, occupations. Um, there's just, I think, so many things. Unfortunately, there's so many things and so little time, I feel like, often in the office. But I know I didn't receive any formal training about this as a lung doctor, and have only become increasingly aware of trying to, counsel my patients about some of that stuff. Obviously, you want your patients on the correct medications. You want them getting appropriate screenings, vaccinations, pulmonary rehabilitation, which we've spent a little bit of time talking about. But I think that's also huge. What am I forgetting?
I'm going to ask you a question because you taught me something a few years ago, which is that there's more than one way to get COPD. It's not just having adult lungs that are destroyed by tobacco or other combustible, but it's that many individuals who currently have COPD have it not because their lung function is deteriorating rapidly, but because they never reached the appropriate level of lung function, probably because of what they were exposed to in much younger ages. So this starts early. And to the degree we can advocate for clean air, I think as physicians, it's our responsibility to do so.
I mean, there's some interesting data suggesting that, mothers, for instance, that are exposed to nicotine, it may promote the development of long and tortuous airways in the infant, then predisposing them to obstructive airways when they are born. So if you are an infant and your mother smoked, you are at increased risk for developing COPD potentially yourself. So when I know, at least when I was in med school, we always thought about the traditional Fletcher-Peto model, and we just made this assumption, probably a very false assumption, that everybody's just getting to adulthood unscathed, and that this, because we're adult pulmonologists, and we think, well, this is the starting point, clearly, and that it's just various levels of downhill depending on what you do. And we're now realizing it's probably more than COPD. It's probably almost everything lung health and lung disease related probably does start in the womb. And so educating pregnant women, protecting children against respiratory infections as children, again, secondhand smoke and air pollution, both within the home and outside the home, as we grow up. There's actually some interesting data to suggest that peak exercise capacity, peak aerobic capacity in younger life actually predicts better lung function later in life. And we don't know if it's just that those people are stronger and therefore have better kind of bellows function and are blowing better on their pulmonary function testing. It's possible. Another hypothesis, though, is that maybe the exercise itself is anti-inflammatory. And that somehow is protective. I think that this whole idea that there might be, it's really interesting. There's all this data on various growth curves, right? So we measure the growth curves of children to see if something's going off with respect to height and weight. We never measure lung function. But if you look at population-based studies or studies that were done, as part of cohort data, particularly pediatric cohorts, what's really interesting is the trajectories are all over the place. You have some people that start off low and then are somehow manage to recover, other people that start off normal and then for whatever reason just spin out and never reach peak lung function. But in the majority of patients, unfortunately, we don't know. So this is actually one of the reasons why Gold is contemplating coming out with a document this year that I'm working on, arguing for universal spirometry at 21. That's not a recommendation yet, but part of the challenge is I think that I don't know, I'd be curious for the rest of yours, for everyone else's thought, but there's been a lot of discussion about lung function interpretation and which equations we use and how do you define airflow obstruction. Gold is still going with the FEV1 to FVC ratio of less than 0.7 because it's really easy and everybody can remember it and it relates to outcomes. But I think what's becoming clear is that one point in time is not maybe less helpful than having multiple points in time. And maybe to really interpret someone's health or lack of health, we need at least 2 points on a line as opposed to 1 point because we don't really know where people started. So I think if you frame the question a little bit differently, then maybe we can make a stronger case. U.S. Preventive Services Task Force keeps coming back and saying, "Oh, we don't bother, no for population-based screening for COPD." But the problem is then we still have half of patients undiagnosed and many patients still picked up late, and we just can't seem to get out of this cycle. So I think if we step back for a moment and say, "Okay, fine." We're not trying to, the main argument has been, well, there's nothing different you would do. You're still going to argue for smoking cessation. You're still going to tell people to live healthy lives, and you're still not going to start medications until they're symptomatic. But I think if we can actually say, that we're asking the wrong question. The question we should be asking is, how can I even gauge health and disease in these patients? And by having measurements earlier and more often, I think it'll be much easier for us as clinicians to figure out what's going on.
You said something really interesting about United States Preventive Services Task Force, and nothing against USPSTF, wonderful, smart, incredible people, but their entire world is built around screening asymptomatic people. And I think that when you talk about we asked the wrong question, the question when I ask medical students, residents, fellows, how do you assess whether somebody has symptoms? They ask, are you out of breath? And I think the question should be, not are you out of breath, but do you limit your activity because getting out of breath makes you uncomfortable? I think if we change that, then all of a sudden a lot more people are going to be symptomatic and they should be given spirometry. It's no longer screening at that point in time. It's a diagnostic test. So I think the difference between screening and diagnostic tests, which I think about all the time with CT scans, applies to a lot of tests and how you define what symptomatic is for people that have obstructive lung disease. I think they begin to make their lives smaller because activity is uncomfortable.
Yeah, but they're not dysmic.
So we've reached the end of our questions, and I want to give the panel sort of a chance to address the key takeaways and maybe discuss what advances you see on the horizon for treating patients with COPD.
Well, I have to say, as someone that does clinical trials in COPD, this is probably the most exciting time that I've ever, seen. Like I said, or like Dr. Labaki said, we've just been in this desert for the last 10 years. And not necessarily that the treatments in the last year, going to cure the disease, but just the fact that we have new treatments is something to chat about. And I think it's really just the beginning, because it just signals that we can actually get trials done and actually have an impact and be able to measure it. And it's giving hope and further impetus for other people to jump in and say, well, then let's look at these pathways and maybe this can be done. And because it has been one of the biggest challenges I think about COPD when we talk about development of new therapies is it's slow to progress. And because it's slow to progress, therefore it's hard to bend the curve in a very short time frame. And therefore, to make a clinical trial feasible. So that's been a huge challenge. So I'm very excited. There's all sorts of drugs that are being looked at, some more in the type 2 inflammation pathway, which are drugs, that were in asthma and are being repurposed. But to me, what's more exciting is there's multiple other pathways. IL-33 inhibitors are probably the next round of medications that are going to be looked at. But I think probably in the next, say, 5 years, we're going to likely see additional biologics. There are other companies that are working on new bronchoscopic interventions. And so I think we're all, all potentially excited about that. I think one of the other places where there's a lot of interest, but we need to do more clinical trials is, do we need to start earlier? And again, those are really hard studies to do because you then have to prove that you can kind of bend the curve, and it takes a long amount of time to do so. And so a lot of people are thinking hard about how we can design studies to help us answer that question of how we can of intervening early. And so we don't have the answer to that yet, but I think it's definitely, something I think about a lot is, would our patients be a lot better off if we, first diagnosed them earlier, and then second got them started on treatment earlier. I don't know if you have other thoughts.
Yeah, I totally agree with that. And I will add, like, people may wonder, okay, we had 2 new therapies approved for COPD this past year, and also there may be more on the horizons. So how do you pick which therapy to go with? Where do you start? How does this play out? And I will say, COPD is a very heterogeneous disease, and it really comes down to the concept of phenotype. And this is important to address in the clinic and try to understand what phenotype a given patient has by looking at their pulmonary function tests, at their blood work, at their CAT scans. For example, a patient with recurrent exacerbations and they are not currently smoking and they have no contraindications to chronic azithromycin in terms of QTc prolongation or cardiovascular events, this may be a good therapy for that patient. Another example, someone with recurrent exacerbations, they have the chronic bronchitis phenotype, which means chronic cough and mucus production on a daily basis. Roflumilast, the oral phosphodiesterase 4 inhibitor that Dr. Hanna was talking about at the very beginning, may be a good option. Another example, recurrent exacerbations and evidence of type 2 inflammation, specifically by seeing evidence of a high blood eosinophil count of 300 or more in their history, then you should think about dupilumab, which we just talked about.
Question for you about that. All right, so the patients just come off a 5-day course of steroids and you're seeing them in the office. That's not the time to check their eosinophil count, is it?
Absolutely not. Absolutely not. More often than not, that eosinophil count would be 0 because this systemic corticosteroid will suppress it all the way down to 0. I would wait at least 2 weeks to recheck it. Or many times, because CBCs with differential are frequently obtained in practice, you can look back at their history. But again, you have to understand the context in which they were drawn, meaning if that patient was in the ED receiving steroids for their COPD exacerbation and that CBC represents that context, then you should not go by that. And to keep going on with the idea of phenotypes, someone who has significant dyspnea despite triple inhaler therapy, despite pulmonary rehabilitation, you can think of adding ensifentrine per the clinical trials result we had last year and per GOLD recommendations. But moving on to the interventional side of things, someone who has evidence of emphysema on their CAT scan, especially if it is severe in nature, and even so, if it is heterogeneous in nature, meaning there is a specific lobe or part of the lung that is way more emphysematous than other parts of the lung, you should consider bronchoscopic lung volume reduction through the valves that Dr. Cardenas was talking about, specifically target that lobe. And also, if someone has evidence of severe bilateral upper lobe predominant emphysema, lung volume reduction surgery may be an option for this patient. So all I'm saying is it really depends on the phenotype. You can target therapy accordingly. Some patients fit within a single phenotype, but more often than not, a given patient will have more than one phenotype, overlapping phenotypes, and how to strategize which therapy to start, whether sequentially or concurrently, it depends on what exactly is going on with that patient, but also the patient-physician discussion about informing the patient of all these treatments, what their evidence base is, and taking into account the patient's preference.
I'm curious, Doug, we've been talking about pharmacotherapy, but then we also kind of briefly mentioned smoking cessation. For people that are out there that maybe aren't super comfortable or don't even really know where to start to have that conversation with patients, what would you, are there some top tips about how do I approach smoking cessation with my patients?
I can only tell you how I do it and whether that's the right way or not. The first thing I do is I really do try to make sure the patient knows that I'm not judging them. I want them to know that I understand they probably started when they were teenagers. Teenagers, above all, they want to fit in. And many of the generation, mine and before, the worst thing that could happen to a teenager was to be ostracized. And to be part of a group was I think, again, built into our DNA. So I try to express empathy. The second thing I try to do is help them find the reason to quit. I can't give it to them. This is what's called motivational interviewing, right? You can't just look at someone and say, you have to quit, and then move on to the last, thing on your item. You have to find what their motivation is to quit. And once they have it, you can say, I can't make this easy for you, but I can probably make it easier. I will encourage people above all to try to take FDA-approved pharmacotherapy because it works. You wouldn't send somebody out with hypertension and just say, use willpower to make your blood pressure go down. You wouldn't send somebody out of your office with diabetes and just say, well, if you're just a better person, your sugar will come down. I think of tobacco like any other, tobacco dependence, I think of it like any other chronic illness, and there are medications to help treat it. And they work. They're safe and effective when used correctly. It's probably too much to go into how to use all these medications safely, but there are a lot of great guidelines out there. The American Thoracic Society, the American College of Chest Physicians, the Surgeon General has a report on tobacco cessation. If you have the patience to read it, it's phenomenal. It's long, but it came out in 2020. And it's the Surgeon General's. Surgeon General has been putting out reports on tobacco since 1964, but it was the first time the Surgeon General actually put out a guideline on how to help people stop smoking. So very useful, lots of resources. Your institutions, if you work at a hospital that has a tobacco cessation service, use it. Take the burden off your shoulders and refer your patients to your tobacco treatment specialists. But I try to do two things. I try to make sure the patient feels empathy from me. I try to make sure that they have a plan to quit. I encourage people to not quit quitting. Mark Twain said smoking cessation was the easiest thing I've ever done. I did it thousands of times. It's funny, it's an icebreaker, but it's true, right? It's not a single time effort. You're not going to climb to the top of the mountain the first time you go. You'll get there eventually if you keep climbing. I don't know. I could probably go on forever with this, but I think empathy is the number one ingredient to help patients who use tobacco commit to quitting. Once they commit, you're their resource.
So I do want to give some time to our audience questions. There is one that's sort of related to that. Will there be guidance in the future for lung cancer screening in respects to cannabis use or the inhalation of cannabis?
So I don't know. So there's nothing magic about tobacco except for the nicotine, which is addicting. So anything that you combust and put in your lungs has the capacity to induce inflammation, which is what we think drives COPD, lung cancer, and cardiovascular disease. So my advice to people who smoke cannabis and are concerned about lung cancer is the only thing that should go in your lungs is air. Cannabis, for better or for worse, is legal now. I have my opinions on this. I think there are ways to get it that don't involve exposing your lung to combustible. It's the combustion that causes the problem. And so, it's the thing I said earlier, 800-pound gorilla. Lung Cancer's association with tobacco took 30 or 40 years to establish that connection. And part of it was it's relatively easy to quantitatively measure someone's exposure to lung cancer. How many packs do you smoke and for how many years? And you multiply those together and there's pack years. I have no clue how to do that for cannabis. Other than
Or vaping for that
or
matter.
vaping or any, it's a lot harder to quantify. And I get the same question about secondhand tobacco smoke, which is what I call involuntary smoking. There's no such thing as environmental tobacco smoke. That's a term that was coined by the tobacco industry. So I struggle with that because I'm sure there's increased risk. It's probably not as great as it is with tobacco. But on the other hand, most cannabis is not smoked with a filter. So that's a difficult question that I can't answer.
What I can say is we are actually participating in the American Lung Association Lung Health Cohort, and we're bringing in sort of asymptomatic, walking, out on the street, community dwelling, 25 to 35-year-olds that are willing to come in and do a pulmonary function test and get a CT scan. And I will say I've been shocked at the range of abnormalities, not all, of course, but that I'm picking up on these CT scans. And for all the world, some of them look like they've got respiratory bronchiolitis that we would typically associate with cigarette smoke. And then when I'm calling them, I have been getting information like I've been vaping or I've been smoking marijuana. So at least on the kind of what the early stages looks like, it's indistinguishable from what I've seen. And not one of these individuals was aware before I mentioned it that, that there was really anything going on. Yeah, they were completely asymptomatic. So it does really make, make me concerned about what we're going to see in 5, 10, 15, and 20 years.
Okay, in our last 5 minutes or so, we have 2 more questions. Any tips for combining LABA agents with LAMA agents in emergency patients with COPD that get worse for any reason? Who wants to take that?
Can you repeat that? So LABA/LAMAs in which patients?
Emergency. Maybe patients going to the emergency room?
Emergency.
Not sure.
Well, so LAMAs and LABAs, so long-acting muscarinic antagonists, long-acting beta agonists, are 2 cornerstones of COPD therapy. They're available in short-acting forms, long-acting forms. They're available in, inhalers. They're available in nebulized format, and we use them. We use them all the time. I'm trying to imagine what the question. Maintenance. It's mostly maintenance therapy.
But you wouldn't use it in for some, would you use these in someone who's, say, admitted to the hospital for a COPD exacerbation?
Yeah, this always gets to be a little bit of a tricky question, is what to do about the maintenance medications when we're bringing people in. So the dogma, I have to admit, I don't know that I've seen as much data on this, but the dogma has been that it's okay to put short-acting beta agonists on top of long-acting beta agonists, but they generally recommend against putting short-acting muscarinic antagonists on top of long-acting muscarinic antagonists because of concerns for side effects. And so if you go by that dogma, and when when people bring it, are coming in, one option is leave them on their long-acting inhalers, but add albuterol. Right. So you can add albuterol on top of whatever it is they're supposed to be taking. And then you can, usually, there'll be additional consideration for antibiotics and steroids. If you really want to switch to something like a duoneb, which, so albuterol and ipratropium, then in theory, you would take them off of the long-acting muscarinic antagonist at the same time, but you could potentially leave them on there. But I think in terms of what actually happens up on the wards, I think it's probably a free-for-all. I don't know if you have other thoughts, Wassim.
Yeah, I generally like to keep them on their maintenance inhaler therapy and use a short-acting beta agonist like albuterol for rescue. The reason I like to do that is because I don't like to interrupt their maintenance inhalers, because I want to reinforce the point of these inhalers are for maintenance. They should be used every single day, regardless of your symptom status, So because sometimes when you interrupt therapy with these inhalers, when patients are in the hospital, they forget to resume them when they restart, or even worse, sometimes they are totally confused about what's going on, what I should start, what I should not start. So this is why I would favor that approach.
Okay, we might have time for one more. Any developments in treatment for asthma COPD overlap?
So, this is kind of challenging because the FDA has been really, really strict on making sure COPD patients are excluded from asthma studies and making sure asthma studies are excluded from COPD studies. And from their perspective, if you have a drug that works in asthma, it works in asthma and COPD overlap, and they don't even think it's an issue or a question. But yet we in the clinic struggle with this kind of seeing patients like this that maybe don't quite fit completely for one or the other. What I would say though is, I was part of an NIH workshop a few years ago, and what an asthma COPD overlap patient looks like is very different depending on who you ask. It might be a patient who has maybe more COPD but with type 2 inflammation, but when you ask an asthma doctor, for them it might be that patient with fixed airflow obstruction who actually doesn't have type 2 inflammation. So what I would say is we definitely have some drugs that seem to work on a type 2 inflammation pathway regardless of what you call them. So for a medication like dupilumab, if you have elevated eosinophils and other signs, elevated FeNO, for instance, I know that's not available everywhere. We have it here and can check it. So if you have, patients that look like they're type 2 inflammation pathway, regardless of their tobacco history, regardless of whether they're labeled asthma, regardless of whether they're labeled COPD, that is, a drug like dupilumab, for instance, is likely going to benefit both. We are looking at drugs right now, benralizumab and mepolizumab, IL-5 inhibitors, which are approved in asthma, so far have not worked in COPD, but I think it may be that the eosinophil counts or thresholds that were used in the original trials were off. They're being redone. So, and at least the press release on the MEPO study, looking at EOS 300 and over in COPD looks positive. So I think it's probably looking more at the type of inflammation. But this is where the labels get us tripped up sometimes.
All right. I think the other questions probably are impossible to answer in 1 minute. So I just wanted to thank our panelists again, Dr. Hahn, Dr. Arenberg, Dr. Labaki, Dr. De Cardenas, and thank you to everyone who joined today. It's great to have you, and this will be available as a recording later. Thanks.